Very good afternoon and very good evening to everyone. I'm joining from Delhi. And as Sangeet mentioned, welcome to our last session. I can't believe we are on the last session. And today, yes, we are going to discuss and learn about community-based palliative care service delivery. We will have two presentations by Professor Kirsten Auret and Dr. Robyn Keall for about 70 to 75 minutes. And then we will have a simple closing session where we will be joined by the President of the National Medical Service, Bhutan. But for now, let me introduce our faculty for today. Professor Kirsten Auret is a clinical director of palliative care for Western Australia Country Health Service and a specialist physician in palliative medicine and general medicine. She's based in Albany in Western Australia. Kirsten is also a professor at the Rural Clinical School at the University of Western Australia, and she was among the team of amazing PhD supervisors I had. Kirsten has more than 20 years of clinical experience as a consultant physician in palliative medicine and has significant practical experiences in discussing advanced care planning with patients and their families. She has published in this area and teaches advanced care planning conversation skills. Kirsten has more than 50 peer-reviewed publications. And recently, on the Australian Day on 26th January 2024, Kirsten was honored with a significant service to palliative care medicine and tertiary education. Congratulations, Kirsten, for this very well-deserved honor. And I've known Kirsten as an amazing human being. And Dr. Robyn Keall is a registered nurse with extensive experience in palliative care in both the inpatient and community settings. Robyn has been practicing as a nurse practitioner since 2015, based in the Community Palliative Care Service in Northern Sydney Local Health District. She has completed a PhD in 2014 through the University of Sydney with the focus on enhancement of existential and spiritual care for patients with advanced life-threatening illnesses from both nurses and patients' perspectives. Robyn has published several articles, and most recently in collaboration with Professor Melanie Lowell, with a systematic review of assessment approaches to predict opioid misuse in people with cancer. Robyn is interested in improving outcomes for patients and carers with use of patient-reported outcome measures and increasing patient self-management. Very interesting. Welcome to the session, Kirsten and Robyn, and over to you, Kirsten. Thank you.
Thank you, Tara. I hope everybody can still hear me.
Yes.
Thank you.
Yeah.
Thank you. And just checking, would you like me to run my own slides, Sanjeev, or would you run them for me?
I'm happy to help from sharing my slide also.
Okay.
Sure.
Well, I'm very happy for you to start sharing slides. Just so I know, will people still be able to see me as the presenter?
Yeah, sure.
Excellent. Well, thank you so much for that welcome, Tara, and lovely to see you again, Robyn, on the other side of the country. It's an honour to be presenting with you. I also am very grateful for the opportunity to speak with you. I had hoped to visit you in person before this day. Tara and I made many great plans, but maybe I can come and visit you sometime in the years ahead. I was very excited to be asked to talk about care in the community, because that is really where I feel I love palliative care the most. It's definitely where I think you can really bring all parts of yourself to the care of the person and their family, and you meet them in a place that's much more human and much more family-centered than when you're caring for them in a hospital. So we'll move on to my first slide. We plan to talk in my section for 20 minutes or so. We'll see how I go with my time management. And then Robyn will be leading us through a case discussion where we can start to see some of the things I'm going to talk about now really demonstrated. But I think there's now very strong evidence that delivery of palliative care into the community, with most models being a community nursing-based service, has a huge impact on the experience of patients and their families. So they spend less time in hospital and more time where they want to be, which is at home and in their own communities. They use less of the acute medical services such as the emergency department and have less unplanned presentations to care. And overall, they have better symptom control for many reasons, including what's Robyn's passion, which is better self-management of their symptoms. So overall, patients that are cared for under community palliative care have improved quality of life and higher patient carer satisfaction. I'm happy to go to the next slide. So because of this, the World Health Organization and many groups around the world have really emphasized the importance of community-based, primary care-based palliative care as the most important way to ensure equity of access. So really, care in the home is where new services need to be paying attention. I know for me, I work in a rural environment. The service that I run is over the vast state of Western Australia, and we look after about 1,600 patients in their own homes at the moment. And home-based care is so highly valued, but making it accessible and sustainable over long and vast distances with smaller resources can be a real challenge. So I don't want to minimise the challenges of delivering home-based palliative care, but I think it's very much what our peak bodies say we should be aiming for, and it's what patients and families definitely are asking for. The next slide, thank you. So what I thought I would do is really just spend a little bit of time talking about, well, if you're caring for someone at home, are they different? So here in Australia, many of us that work in specialist palliative care are involved with a program where we talk to patients about their experience, we help them rate their current symptoms and their distress, and then we feed that information into a large database called the Palliative Care Outcomes Collaborative, which helps us understand what are the problems our patients are experiencing. So this chart that you can see on the left of the screen is from December 2023, so very recent information of about 19,000 Australian patients being cared for in palliative care in their home. The average age of these patients was about 76 years old, and the amount of time that this group of patients spent in the palliative care service in one go before they had a change, for example, dying or going into hospital, was about 39 days. And you can see that the amounts of patients that had the kinds of problems that you've been discussing are they're the problems you've been talking about already, but some of those patients will have complex problems, have distress that is moderate or severe in severity. So for example, here we can see that about 25% of family and carers had moderate or severe distress being experienced when they first came into a community palliative care service in Australia. About 25% of patients were suffering moderate to severe fatigue. About 15% had moderate to severe pain. They had problems with their breathing, their bowels, nausea, appetite, and difficulty sleeping. So I think that's really useful because it gives us a bit of a sense of what sorts of problems might Australian palliative care patients being cared for in the community have when I walk through the door. But equally on our next slide, if you have a look at this amazing work done by Tara. So this is from the paper that she published in the BMC Palliative Care in 2021. And it's such an important exploration of the same sort of idea. It's 70 patients, 14 of whom were in the community at the time they were recruited. And it gives us an idea of what sorts of problems might we be facing for patients we're looking after in their own home. So I know this slide has been shown to you before in one of your earlier lectures. And I'd just like to highlight both the functioning scales and the symptom scales. So the functioning scales are rated from 0 to 100, where a higher number means better function. And you can see overall that this group of patients rated their overall quality of life at about 47 out of 100. And there were some areas where they were really struggling overall in their ability to fulfill their role, in their emotional sense of well-being, and in their social connectedness. And Robyn will come and touch on some of these issues again, those really core values that you like to be able to enact in your personhood and in your family. But playing the role as a mother, which in my example, as a worker, as a doctor, as a breadwinner in the family, as a caregiver, so many of those roles that are lost are very acutely felt in the home situation. And equally, just like our very large Australian cohort, the symptom problems are broad and can be severe. So again, like our cohort, fatigue in your cohort is a very big problem. And you can see the range of other symptoms. But I'd really like to highlight the bottom one, severity of distress around financial impact. So here 74 is a high number because 0 means no distress, low severity, and 100 is high distress. So there's a lot of issues about actually just affording life and care for our patients in palliative care. So again, if we move on to the next slide, and this comes again from Tara's work in Bhutan, talking to 40 family members of patients with advanced disease. And definitely, once you move into the community, you are moving into that person's family. So this understanding of the needs of the family members really come to the fore. And so much of the care that we plan and deliver in the community entwines the care of the patient and the care of the family. It both relieves the distress together, but it also uses the strengths that come from being part of a family. But I think this doesn't surprise me really. Australian patients' families, I would say, is very similar, but many family members want lots more information about the illness that their loved one is experiencing. What's happening now? Why is it happening? What might the future hold particularly? What's the person's prognosis? How can I best help them? How can I manage their symptoms? How can I deal with my feelings? How can I look after myself? How can I get a break overnight? How can I get practical help? So these kinds of problems that were experienced in Bhutanese family members are the ones that we really walk into the space and share when we are caring in community. So thank you. On to the next one. Now with this one, and I know you've had some amazing communication sessions because I watched them in the recordings. I think when we are in someone's home and we're providing palliative care in someone's home, it's much, much harder to hide behind your stethoscope and your white coat. And you get involved in very complex conversations that need to be held with great sensitivity. And it's often very difficult to explain, for example, why you're in someone's home when someone doesn't appear to understand how sick they are, or whose family members are still struggling to decide how much of the diagnosis will we be talking about, how will we talk about these things openly in our family. And Tara's work again shows that just like in Australia, but perhaps more so, Bhutanese families are struggling with how will we talk about what's happening? How will we share the diagnosis? How will we do that in a way that's loving and hopeful and is best for the person that we love? So the families Tara's talked to said that many of the patients that they were caring for who had advanced illness, they didn't think their relative knew the diagnosis. And about half of them wished that they did know and felt that that would make it easier and better for everyone, and the other half didn't. So when you're doing nursing in the community, that's a big thing. It's a very, very big, in Australia we call that the elephant in the room. That big thing that we're all working around and no one quite knows how to bring it up. So Tara's group of family caregivers talked about how that desire for ongoing hope for living is so important and how can we nurture that. But equally being very concerned that some of the communication happening around the bedside might even be dangerous, that the word cancer will depress her. So thank you. On to the next one. I'm hoping when we talk a little bit more about Robyn's case through the chat or through questions, you can explore with us how some of these issues might be explored, dealt with in an experienced and mature community-based palliative care service such as the one that Robyn works for. But as we're building community palliative care services, there are things that make things easier and there are things that make things harder. And I'm definitely very aware of the harder. When I started this role 4 years ago, we had very little palliative care in the community in some of our more remote locations, particularly in some of the places that are far away in the desert, far away in the bush, perhaps very small communities, very few people there with jobs, perhaps only a nursing post, definitely no hospital. So some of the barriers around lack of primary care at all, lack of knowledge and skills, no money to deliver care that's further away and perhaps therefore more expensive, problems getting opioids actually to people where they lived and other medications, definitely lack of nurses, lack of doctors, and very poor identification of the kinds of patients that palliative care is good for. So a belief that palliative care is only for those last days of life and only for old people and only for people with cancer. These are the kinds of barriers that we've faced here in rural Western Australia. But equally, just like the World Health Organization framework points out, that the flip to that are almost the same things. That education actually like this can make a profound difference to the kinds of care we can deliver in the community. And a lot of what we need to deliver is what I would consider fundamental nursing care with some extra knowledge. So much of the palliative care we'll deliver in the community is good, basic, compassionate, sensible care with some extra skills. Equally, having that kind of infrastructure where you can have members of the team working together, who have secure work, who know how they're going to get from A to B to see the patients, and that we're working within a framework where we actually can get the basics of what we need, particularly access to the resources that are essential for symptom control at the end of life. Obviously, having access to some sort of community-based primary care that involves people that can prescribe is very important. As well as that, though, I think this policy idea that communities themselves will take some time to understand what palliative care is and to feel that it's safe and okay to let palliative care into your home and into your world. Again, in my practice where I care for many Indigenous Australians, Aboriginal people, particularly those who live in more remote environments, palliative care has been almost taboo, and talking about death has been taboo in the past. And so having a very gentle approach to bringing the community with us has been very important to developing community palliative care. So on to the next slide, which I think for me really just shows that same idea again. I know this slide has been shown to you before, and this particular publication came from India, sharing the World Health Organization Public Health Strategy for Palliative Care, that you need all those elements to come together to deliver community palliative care. So if we move on to the next slide, I had a lovely, lovely time, and I'm so sorry this is the first time I've been here in person, but I had a lovely time listening to the recordings of the cases that you have been presenting, because they have been moving, they have been difficult, they have been compassionately and skilled care being demonstrated. And I thought about some of the words and ideas and issues that you've touched while you've been discussing these cases in your seminars to date. And I put them into a word cloud and I thought, you know what? That's community palliative care right there. The sorts of things that you've been talking about in your cases is community palliative care. It's about who someone was. They're a young man who has children. They're an isolated woman living with her mother. They're a worried parent. They're a loved family member. They might be an isolated family member. They worry about how to talk to each other. They worry about pain, suffering, spirituality. They feel alone. They're physically disabled. They're often suffering quite terrible symptoms in some of your cases, and we see that at home for sure. And just like we've been talking about, the symptom scope, many symptoms, often quite severe. are the sorts of cases that you've been talking about and talking about how you can manage them very successfully. So I found that really powerful, and I hope that you have come back to that kind of reflection yourself. So I'd like in the next slide just to talk to you a little bit more about how we, sort of very broad models of how we deliver palliative care in Australia. So we are very blessed to have a well-integrated, for the most part, community palliative care models. You know, when you have a lot, you always feel like you could have more. So if you had a whole bunch of Australians here, we would probably be moaning about how community palliative care could be much stronger. But essentially, we have three main types of models that patients will be offered, primarily, hopefully, dependent on their need, but perhaps dependent on where they live, or what choices they have made, ideally what choices they have made, but probably mostly based on need and where they live. Sometimes based on diagnosis. So for example, if the person has dementia, would they have this same thing than if they had cancer, even in Australia? So the first model is that our primary care services, which are primarily our general practitioners and community nursing services, work together to provide all the palliative care for that person. They talk about what's happening now. They support the family physically, emotionally, psychologically, and spiritually. They make sure that the patient has access to the medicines they need. The nurses do the care. The local doctor provides all the medical guidance that's required. And for many people, they will be getting excellent palliative care in a very community-based primary care model. However, the middle ground is where a lot of our patients get very good outcomes. So they have access to community nursing and general practice, but they also have access directly or via the nurses and general practitioners looking after them to a specialist palliative care team. So as there is more complexity, or as the nurses and general practitioners involved feel like they're struggling, they're able to reach out to a specialist team and get extra help and advice. And for a smaller cohort of patients, at least where I live and work in a more rural environment, they will get their community palliative care pretty much only by specialist palliative care teams. So specialist nurses, for example, like Robyn, specialist doctors like myself, and a broad specialist MDT. So those are the three main models. They all have evidence for their efficacy. They all have strengths and weaknesses. Some are more expensive to deliver, some are cheaper to deliver, some have more expertise around complexity and more difficult problems, and some have less. But I think the relationship between very community-based services and specialist palliative care services, a working, functional, happy, healthy relationship, gives great outcomes for patients. And that's the model I work in most of the time. So yes, we are on the next slide. Thank you so much. So if you ask, what does a specialist palliative care team that delivers care in the community in Australia look like? They are a multidisciplinary team. Strong teams will work in an interdisciplinary way. And by that, I mean that each of these disciplines or professions is happy to work a little bit outside what's seen as their traditional scope. So for example, myself as a doctor might be happy to help with a bed bath while I'm there. The pharmacist might be happy to sit and listen to that wife's grief when she actually went to the house to go and deliver some medications. The spiritual care practitioner may be happy to make a cup of tea and fluff the bed. So an interdisciplinary team, I think, is ideal in palliative care, where people with different scopes of practice and base professions work together for the best outcomes of the patient. And they're able to bring all of their selves and all of their skills to that patient, and they're not necessarily limited by, this is what doctors do, this is what nurses do, this is what social workers do. A multidisciplinary team is one that may have all the same names around the table, all in my list there, but tend to work a little bit more as devising a plan of care that is within their scope, and then coming together perhaps a little bit intermittently to try and bring the plan together. So this idea of multidisciplinary team versus interdisciplinary team is one that you would continue to discuss as you built your community teams and as you thought, how can we work together? How is our roles going to be delineated? Is there going to be a bit of blurring at the edges? That sort of thing. So let's move on to the next slide. I think the other thing that we have in Australia when we're talking about community palliative care is all the stuff other than staff that allow it to work. And definitely access to comfort medications, of which Bhutan has a very useful list of essential medications. They're the kinds of things I need, and they're the kinds of things you'll need. So access to those medications in a way that is affordable to the patient and that can get to the patient's home and can be taken in by the patient. So for example, if they can't swallow, how is that person going to get medications in their home? We need access to equipment, but sometimes not very fancy equipment. And sometimes, particularly in more remote areas, we kind of what we call jerry-rig, which is an Australian way of saying we just make it up as best we can. So we have the farmer that's welds together some contraption that helps them move in bed. Or we have a carpenter in the family that builds a special way of the person being able to slide from one bed to a chair. But there's also obviously a lot of equipment that's been designed specifically for people who are frail, who are disabled, who are very weak, to be able to move, to be able to breathe, to be able to open their bowels and their bladder. And those access to some equipment to make life easier, particularly around pressure area management and mobility and continence, definitely helps. Access to dressings, continence aids, perhaps special foods. So particularly in Australia, many of our patients are given access to some sort of supplement. So a high protein, high calorie supplement, particularly when they're still in a phase where they're trying to maintain their strength and function. We have access to bespoke family and patient information resources. So for our Aboriginal community, that may be in language. For our people that speak Italian or Chinese, or unfortunately not only Bhutanese. I've not seen an Australian palliative care brochure translated into Bhutanese yet, but perhaps Tara has. But we have family and patient resources that are available to us that have been really well worked up. They're in language, they've got the right literacy, they really help us in our work. I use telehealth a lot. I review a lot of my remote patients with their phone and my phone, and we see each other that way and we talk and plan care that way. Transport, very important. Very hard to care for people in community if you can't get to them. It's cars, planes, and legs for us here in Australia. Financial support, ongoing education, upskilling, and debriefing perhaps goes without saying. And on the next slide, you'll see some work from Jessica Bay, who really focused on the emerging field of palliative care in Bhutan when she published this article in 2019. And we are talking about the same basics that have been scaled up over time and over a longer chance of maturity, but it is really around some basic infrastructure, some personnel, very importantly, including volunteers in this model, medication, equipment and documentation availability, and financing in a way that's sustainable. So moving on, I just wanted to spend the last couple of slides talking about what makes things different, because the doctor I am in the hospital is in many ways exactly the same doctor that knocks on someone's door and asks to be let in. But the way I do my doctoring, I feel is quite different. And one of those things is about making the clinical tasks that I need to do look and feel normal, but to still be able to do them. So, for example, I nearly always will still examine a patient, but I'll be doing that in their bed. I'll wash my hands in their own sink. They'll have their own blankets around them. I'll be kneeling beside their bed that doesn't come up and down and whiz and bang. It's their bed. I have warm hands. I kneel beside them. I might have the dog on the bed with me or the child clambering around me. But I'm part of their family. And my role is to make my interactions within that family look and feel normal, not frightening, comfortable. But as well as that, I think what I get so much more easily when I go into someone's home is the ability to assess them in a very real way. So from the moment they or someone else come to the door and let you in, the way you see how they're sitting, breathing, moving, speaking, who touches who can't even look at me. When I just go and offer them something to drink, can they pick up that cup, their own cup? Can they even pick it up? How do they move around? All that assessment happens without me even thinking about it. There's so much observation within the home. That's your normal clinical skills. It just happens in such a different way. And I love this little quote. You wouldn't know she was making something that was a treatment. It would look like you were making a cup of tea. And I think that's a difference. When a patient chooses to die at home, that's what they want. You take out the clinical, it's comfort, home. Such a powerful statement. And I think that's why we all find palliative care at home so special. So on the next slide, I just reflected on some of the other things that I think that about what I really value about working in someone's home. So I've touched on about that ability to use every part of yourself in assessing and managing that person through the conversations you have in the home and the routines that they have in their home. But often there will be a continuity of care and a rapport that is deeper than you can create in a hospital setting. And even if I'm not the one that goes back, I have this sense of continuity of care because they're still at home, if it's my colleague that's gone. And it is much more possible to respect and grow the patient and carer's agency when they're in their own home. And I think I really value trying to be a calming and helpful presence without causing disruption or concern. So the last, I think it's, no, it's not quite the last slide, we're getting there. The next slide talks to how care at home then actually works to get good outcomes. So it may be that one or two of us are in the home, but being able to talk with that person and the family about what might come next, what's important to them, what are their goals and values, and how might we deal with some of these problems that are relatively predictably going to happen in the foreseeable future, advanced care planning. And then going back to our team and talking about that. And you'll see in the case Robyn's going to present all the things that came up for this person at home and how by being proactive and thinking ahead, they were able to be managed still in the home community without emergency presentations or crises. So for me, home care means thinking ahead, always just one step ahead. What could happen next? How will we deal with that? Let's talk about that. Let's put something in place. So again, just coming back to another idea which we were highlighted early on with Tara's slide about the profound financial stress of caring at home. This is real in Australia, even in a high-income country. Carers have a deep sense of urgency about meeting all the person's needs as death approaches, regardless of cost. And that cost can be a lot. In Bhutan, reading Tara's work, hearing about some of the cultural responsibilities and the spiritual care, and wanting to give access to alternative and complementary treatments, or supporting people to travel or family members to come. There are a lot of plain old out-of-pocket expenses, but also many caregivers, particularly those of working age, have to give up work or reduce work or take work that's less responsible and therefore less paid. So once you move into someone's home, you're moving into the reality of this and poverty sometimes. So death at home, thanks Sanjeev, we are on the right one now. He's very good at this, I have to say. It's like he's right in here. Death at home might be something that the family has already experienced, but for many Australian families, it is not. The multi-generational living at home is not so much the way Australian families live anymore. And most people in Australia still die in hospital. So death at home means for many of our families that they are often for the first time seeing a dead person. They might be the first time they're hearing that rattly breathing at the end of life. They're seeing someone become mottled, feeling them get hot and then cold. Perhaps at the end they've lost control of their bowels or that they've been incontinent beforehand. seeing them get stiff as they become rigid and then soft again afterwards. Preparing for the death at home in a way that that family can embrace and not be traumatized for again is about that future planning, and it's about talking. And I think it's about that family just knowing that someone's got their back, that so much of this is normal. There's someone there that's understanding, that's done this before and will help me. And then I see families manage the craziest things, the hardest symptoms, the most tricky situations, because they know that someone is there who will help them. And that's all they want. So that is my last slide. The last two are references, which are in your pack and being shared as part of this presentation. Our plan was for Robyn to go on and present her case, and for me perhaps to interject in a couple of places if needs be, and then for either in the chat with Tara perhaps mediating some of that you could ask questions or you have questions at the end. But I think you'll see with Robyn's presentation much more clearly some of the things that I've talked about in this sort of more didactic lecture. So thank you, and I will be a participant watching Robyn now.
Thank you, Kirsten. And just before I give the floor to Robyn, it's a shame that we are not able to have the president, because she just texted me that she's called to the ministry by the secretary and she says sorry. And so I think it's okay, because that often happens in our context. So, but I think we also will have then more time to discuss and learn more about the very important session. So over to you, Robyn. And yeah, we will have questions and discussions after Robyn's presentation, I think. Thank you. Okay, Robyn, there's some issue, right? Okay. No, Robyn, we cannot. Yeah, we cannot hear you. There's some other noise kind. Yeah, we cannot hear you, and there's some crackling sound, kind of.
From her speaker. I guess so.
I think I had a.
That's
okay.
fine. That's fine. Yeah. Thank you, Robyn.
All right. I'll share my. Am I sharing my screen with you? No.
No, it's not yet there. Yeah, it should be there. Yeah.
Are you getting that now? Or
just... No, not yet.
Sorry, bear with me.
No,
I had it all prepared before.
No, it happens. It happens. Kirsten knows that used to happen to me so many times. Isn't it, Kirsten?
And it still happens to me every day.
Really, it's not working for me today at all. All right, maybe it's better if Sangeeta would show his the slide. Sorry, that's probably better than me fiddling around. I do apologise.
Not a problem at all, Robyn.
Thank you. And if we just go from I'm you. Okay, Lovely, thank you. So firstly, thank you very much to Kirsten for her presentation. That was really informative and very interesting to hear how things are presented from Western Australia. I'm on the other side of the country to Kirsten, but there are lots of similarities, and I really appreciate her presentation. And also thank you to Tara for inviting me to present today. I do just wish to acknowledge that I am presenting to you from Camaragal country in the Eora Nation, and I pay my respects to Indigenous elders past and present and emerging. My name's Robyn Keall and I'm a nurse practitioner, and I'd like to go to the next slide, please. So tonight I'd like to give you a case study presentation. There'll be some didactic information and some education resources, and then an opportunity for questions or comments at the end. Next slide, please. So I just thought I would share with you a picture of what our case study subject did enjoy doing, and that was to look into the bush. And this is some bushland, typical of the area in Northern Sydney local health district where I work. There's some typical bush. You might see some banksias, some gum trees, and this lovely red tree in the front, which is also called an angophora. They've been voted the favourite tree, so that's very nice. Next slide, please. So the setting of Northern Sydney Local Health District, I just thought it was interesting to tell you a little bit about it. It covers 900 square kilometres, and our population is about 920,000 people. Not far off where Bhutan's population is, but our population is a little bit older than yours, and we have about 17% aged over 65 years old. We only have 0.5% who identify as First Nations people, but we do have a reasonably high culturally and linguistically diverse population, with the majority of people of those populations being from China or India. We do have a slightly lower than state average mortality rate, and our deaths for the previous year was 5,600 odd deaths, but the highest cause is cancer, followed closely by cardiovascular disease. Next slide, please. The services that we have available to us in the Northern Sydney Local Health District, and this will change all over the place, but I just appreciate that we are very fortunate to have the opportunity of having several dedicated palliative care beds, like within institutions. We have 50 adult, 8 young adult, and 10 paediatric beds. And the service I work in the community palliative care service, we practice with outpatient clinics. We do use a lot of telehealth, although we certainly don't go as far afield as Kirsten's service covers, and of course home visits. We do have an equipment loan pool that's really important, and Kirsten touched on the equipment that can be very helpful for helping people just remain at home. We have things like bed rails, bed wedges, bedside commodes, lots of things to do with beds, which can help people to keep their independence longer, but also help carers providing that care. And also with things such as walking aids, which can be really important because we want to make sure that everybody's safe, not just the patients, but also the people providing that care are safe. And our equipment loan pool is free to any patients known to our service, of course. And what's really nice is that often when the person has died, the carers will come and give us equipment that they have bought themselves. So it's really nice. It's like paying it forward. And I think that's lovely to be able to share that equipment. Our service partners with local community nursing teams and government-funded home care providers. So our model of care is like the middle one that Kirsten mentioned before. We do partner, of course, with general practitioners or local doctors and specialists. And we have a 24-hour telephone support line, which is something that we're was very hard fought. It has been incredibly helpful service to have, and it is answered. Our phone is answered by a nurse, and it provides just so much reassurance. Sometimes it's can be just so much as having someone listen. A lot of times it's majority of carers will call with concerns, and they just can have some gentle guidance about what perhaps the next treatment someone should have, take a little bit more medication of this or that. But often it's just having someone to talk to in the middle of the night. Next slide, please. So I wanted to just give you some preface the case study as well with some information that we're using that we use to help communicate. Sorry, some tools that we use to communicate care needs for our patients. And Kirsten mentioned this before and actually showed that example of the symptoms that people experience, and that was using one of the tools from the Peacock suite, and that was from the SAS, or the Symptom Assessment Scale, and the patient-related score. I always get that wrong, the bottom two. But the one that the two that I really want to raise your attention to, that I'm going to use to illustrate this case study, is the RUG ADL and the AKPS. And if we can go on to the next slide, please. So the RUG ADL, or the Resource Utilisation Group Activities of Daily Living scale, it's a 4-item scale, and it measures motor function. So it's really looking at how independent is this person, what can they do by themselves. So the scales, the ratings between 1 and 5, or 1 and 3 for eating, and for most of us we would have a RUG ADL of 4 because we're independent and able to get ourselves to the bathroom, get in and out of bed, etc. But the numbers go up, and so if somebody needs help turning over in bed, if it's just one person gently turning them over, or if they really need a slide sheet, they might score higher on that. Or if somebody transferring actually needs a hoist, 2 people in a hoist, they will score 5. So as the scales go up, the highest number a person can score is 18, and then they are fully dependent. Next slide, please. The other scale that we use is the AKPS. It is also, some of you may know the Karnofsky Performance Status, and this has just been a little bit modified for the Australian population. We use this. This indicates a person's independence and their ability to self-manage. So, and that's between 0 to 100. 0 being dead, 100 hopefully that's what we all are, able to get along with no evidence of disease. For most people, when we would meet them, say in a palliative care service, they'd probably be around the 70 mark, able to self-care, maybe not able to work, or for those who are just able to help, give themselves a shower but might need a little bit of assistance. Say, for example, an AKPS of 60, they might be able to shower, but they need someone to help them put their clothes on and prepare their meals. Next slide, please. But for those of you who don't know the AKPS or the RUG, you may be more acquainted with ECOG, and a lot of people do know ECOG. And so they've put here, this is the Karnofsky to the ECOG. So for example, again, we're probably a Karnofsky or AKPS of 100, and that would be ECOG grade 0. As things go on, obviously the numbers, as the Karnofsky gets lower, the ECOG gets higher. But for those patients who I just mentioned, being able to shower themselves but needing help putting their clothes on, they might be an ECOG 2, and so on. Next slide, please. Thank you. The other part that I want to mention, I'll mention each time we discuss our case study, is goals of care. And goals of care are what a patient wishes that they want. What are their main wishes? And Kirsten mentioned this before when she was talking in a few occasions, but in big part of it was advanced care planning. Some people might know it as advanced care planning. Some people might say advanced care directives. Others might say living wills. These are documents that people can complete, and it can outline what is important to a person. It might outline what they would be tolerable to them, or what might not be tolerable to them. What are their wishes around what sort of treatment they would like? There's the one that often comes up is, for resuscitation or otherwise. Excuse me. And then also, where would the person be when they come into the end of their life, if they have control over that? The thing we want to always check with people is what is their goal of care when we see them in each meaningful interaction, because they really can change over time depending on what's happening for a person. For example, if a person is at the beginning of their treatment with the hope that they are going to get some respite or reprieve with their treatment, cancer treatment, for example, their goals of care might be that as soon as they become more unwell, they may go back to hospital and have, investigations, antibiotics, blood transfusions, etc. But for somebody who's perhaps more advanced in their illness or for whatever reason has chosen not to, they might not wish to do that. And it's not something that you can assume. And what we do know, that advanced care planning discussions and discussions with families can be incredibly helpful, because people assume because they've been married to this person for so many years or whatever, that they know what they want. But then when we have these conversations, people are actually often surprised. And what we do know from research is that bereavement can actually be improved when people have had advanced care planning discussions, because what I always say to patients is the advanced care plan only comes into action when you're not able to speak for yourself. And I use the example of, say, a stroke. So you will have had a stroke, you're still alive, but you're not able to speak. And so the doctors will turn to your loved one, your next of kin, your spouse, whoever the person is, and say, what would this person want? At that time, if your loved one is aware, they can confidently say, I know what my loved one would want, and this is what we would want. And we do know that for bereavement for those people is actually better, so that they're not second guessing themselves. They're not wondering, did I do too much? Did I not do enough? And I think that's a really important thing to labour. So I often say to patients, by completing your advanced care plan, thinking about what you would like and would not like is a real gift. This is a gift you're giving your family or your next of kin person, to be able to allay that fear that they're making the wrong decision. So the other thing that is also important with goals of care, so that's part of it, is also, being honest with people and asking them, what is it that you would like to do? Because if a person's time is limited, they may have things that they really want to do before they die. They may have friends they want to contact or relationships that they want to mend. They might want to do some legacy work. For example, some people will write letters to their grandchildren or, write birthday cards, important things. And for a lot of people, it's tidying up financial affairs and those sort of things that they just really want to have sorted out for their family. So I'll be mentioning those things along the way. Next slide, please. So it's getting to our case study, and I just want to introduce you to an absolutely delightful woman I had the pleasure to care for. I'll call her JW. And she was a 62-year-old female with metastatic colorectal cancer. She was initially diagnosed with, at that time, was localized cancer in February 2022, and she was treated with a right hemicolectomy. That was fine, and she was just had surveillance. Unfortunately, in June 2023, she developed a bowel obstruction. She was quite unwell, was in hospital, had an ileostomy, and she was so unwell that she had to have TPN while she recovered from the surgery. She had sort of some quite serious surgical problems. So a TPN, you probably know, but I will just mention, is total parenteral nutrition, so fed via a central line. That was okay. She got home, felt that things were going on a steady path. There was some potential discussion about having some treatment. She wasn't really keen, and she was still recovering from this pretty serious surgery that she had. And unfortunately, 3 months later, she started with a lot of vomiting and abdominal pain, and she was diagnosed with a gastric outflow obstruction, which was treated conservatively with steroids, put on a low-fibre diet, and she was in hospital for some time, not terribly long, but for a while, and had imaging at that time that showed that her gastric outflow obstruction was because she had a lot of peritoneal and a mental disease that was progressing. There really wasn't a role for any chemotherapy, and the decision was made for best supportive care, and she was referred to the palliative care service, which was us. Her past medical history included early breast cancer, which she'd had treatment for, some hypertension and depression. Next slide, please. So socially, she was a bookkeeper in a small business with her husband. And I mention this because she continued to work really quite long into her illness after we had met her. She was really diligent. This was one of her legacy work, I think, was to tidy everything up. She was married, as mentioned. She had 2 adult sons, 1 daughter-in-law and 2 grandchildren who lived in Sydney. And she had a supportive sister-in-law who was out of state, and a supportive family, but they again were out of state, in a different state. A very good GP, a general practitioner, sorry, and she didn't have any religious belief. We always check with people, is there something that's important to you? But she drew strength from nature, and she loved to sit on her balcony and observe that bush. And she also liked to have a little sneaky cigarette out there. Next slide, please. Can we go to the next slide, please? Thank you. So no, back one. Thank you. So our first contact was in the outpatients clinic. This was 1 week after she'd been in hospital with the gastric outlet obstruction, and her assessment showed that she had a recurrence of the obstruction. She had forgotten to take her steroids. She'd been advised to continue on these steroids orally, but she had forgotten. She was quite unwell, but she really didn't want to go back to hospital. So we started some subcutaneous steroids, gave her some analgesia and antiemetics, and we used a continuous subcutaneous infusion. We call them a syringe driver, to give her medication continuously through that. She was still on her low fibre diet. We did lots of education with her husband about giving injections and how to use that. We use a butterfly under the skin, so they don't have to jab the person every time, but they still need to be educated how to draw up the medication and how to give it and when to give it, which is really important. And we referred JW to the community nursing service to come and help with that education, because it is an ongoing process and people are overwhelmed with information. So often we need to repeat those things over and over again. And the community nurses could actually draw up the medications and label things and explain why we would use what we would use. The other piece of advice we gave her was that she was developing some oral thrush from the steroids. So we advised taking bicarbonate of soda, a teaspoon in warm water, and rinsing 4 times a day. At this stage, her RAG ADL was 4, so she was independent like us. AKPS was 70, so she was doing quite well, but that's still an ECOG of 2. And her goals of care were quite clear. She didn't want resuscitation, and she really wanted not to go back to an acute hospital. She wanted to go home. Next slide, please. Thank you. So several weeks went by and she was really pretty stable. The subcut medications were continuing, and when I was going to see her at home quite regularly just to check in how she was doing. Lots of times we would just phone, but we'd pop in and see her quite frequently. She was doing quite well, eating and drinking pretty well. Her ileostomy was working 1 to 2 times a day, quite liquid still, which was fine, but her fatigue was increasing. Her RUG ADL by this stage was now 6. She was getting a bit of help. This indicated that her husband was actually helping her with her ileostomy care, because she was getting quite fatigued and it was a bit of a fiddly ileostomy, and she needed a little bit of assistance with that, but she was still able to shower herself, just a little bit of help. Her goals of care, again, were not for resuscitation, but she really wanted to go and see her family interstate via plane, so it was a plane journey. So we figured that probably taking a syringe driver and all these other medications might be a bit challenging. So we looked at her medications, the analgesia, which was going through the infusion, we rotated that to a patch. And I used an opioid calculator to work out that change. And I always educate patients as to why we've made that change, because as you probably know, 1 milligram of morphine is not equal to 1 milligram of oxynorm or fentanyl. So we really like to make it nice and clear. We did keep the subcutaneous butterfly for the as needed pain relief, and she was still having a steroid injection once a day. We were concerned for oral absorption, so we just wanted to keep away from that route. Every now and again, her husband would give her an extra steroid dose, maybe once if her ileostomy had been inactive during the day, and that was working well. So then the ileostomy would consequently work quite well. And we did the documentation about carrying all these drugs. Next slide, please. So her biggest problem at that time was fatigue, and this is, as mentioned before, and interestingly on that scale of symptoms that Kirsten showed us previously, fatigue was actually the highest rated problem, or most frequently rated problem. It's an enormous problem, and it derives a lot of frustration from people about what they can't do and the things they want to do. So we're really, really fortunate. We have an occupational therapist in our service who I referred JW to, and she went to see her at home. She looked at her home setting, she looked at where she was sleeping, her bathroom, her bedroom, the stairs, etc. Talked about energy conservation. They talk about having just a bucket of energy to use for the day, and the bucket's a bit smaller than it used to be. So you just can't. Once the bucket's empty, you can't keep going. So they really give good advice about things they can to help manage it. So something as simple as a shower stool, something to sit on while you're having a shower, or sit on while you're drying yourself, can actually reduce the person's energy expenditure while they're doing that activity. And also about pressure injury prevention, which is a big problem for patients when they're moving less and they lose weight, so they have less adipose tissue. I've got a diagram there. There's the shower stool, but also a bedside commode, which are quite handy. And if you go to the next slide, please. This is Kirsten. Did you want to interject, or just keep going?
I can just very quickly say that when Robyn and I were discussing this lady's care, we talked about the role of equipment, and we're really just highlighting that energy conservation was so important, but it also really does allow improved symptom controls around fatigue and dyspnea. And that many of the things that we do in the home are around the bedroom, the bathroom, and that sort of comfortable space so that the person can be managed in bed. So things like bed rails, slide sheets, trays, a way of calling the family, a bell, closer access to their personal items, and then safety rails, non-slip mats, and just ways that they can access some entertainment, some music, a book, food, etc. Just really in terms of how that room's placed. And a lot of it is perhaps quite common sense, but often people really do need help with that, particularly around decluttering the space and picking the best place in the home for a person to receive care.
Thank you. Next slide, please. So time progressed, and the rug ADL JW's rug ADL was 6 still, but her AKPS was falling 50 now, which is an ECOG of 3, and she was really spending a lot more time in her bed. She was still able to get out, but most of the time was really around her bedroom. Her goals of care was that she, again, did not want resuscitation, but she wanted to celebrate her upcoming 63rd birthday. And we're very fortunate with our service that we have. It's called the Dreams Project, and we're able to. It's funded through donations. People bequeath money or donate money, and they're able to do things that are meaningful. So meaningful activities. We've had some people have, gotten married. There might be some lovely professional photographs of the family together, or going on holidays, or for JW, she wanted to have a party for all of her friends with a Vietnamese theme. And she wanted the Vietnamese theme because her and her husband had travelled to Vietnam many times, and it was very important to them. And we found that out because I literally said to her, "What is important to you now?" Like, that is just a really good question. What is important to you now? Or what is important that we need to know about you? How can we help you now? And so that's how we got to that point. And so that was the plan. It was great. The person I was getting a little bit concerned about was the husband, because, this is week 6 of us knowing JW, but he'd been caring for his wife, really quite concerned, for about 18 months before this as well. And he was getting quite fatigued. He was sleeping really poorly. And interestingly, JW was actually sleeping okay, but her husband, bless him, he would lie awake at night and watch her. He would worry that she would stop breathing. He would be that half awake, half asleep. Like if she murmured in her sleep, he would be awake. So he was really not resting very well. So I explored with him the supports he had available, and a lot of his friends, and for a lot of people this is the case, their support group is through their work. But when they become a carer, they're not going to work, so they lose that that support, or that every day-to-day support. He did get support through his family, and I think they had a nice neighbour or two, but really he was isolated. We offered him, we do have a weekly online carer support group, which was one of the good things out of COVID. We actually used to have a face-to-face support group, and then we went online, which does help more people to attend, but he declined the offer of that. But the thing we did do was we talked about having a family care roster. So he was really on 24/7. He was on, and he had these lovely sons who were happy to help, and in-laws and things. And said, why don't we make a roster and just have a time that you've really got your time off, but you know that there's always someone there with JW, and people want to help. So it was nice just to be able to put that together. Symptomatically, the needing the additional steroid every other day because the ileostomy was really not working very reliably was pretty regularly every other day. We had this routine, and then the subsequent day her ileostomy would work, but it was getting less and less. Mercifully, she had very little vomiting, so that was good. Next slide, please. The following week, really, it was actually after the birthday party, things started to deteriorate, and it does seem to happen for people. Often they'll have something that they're really looking forward to. They get to that point, and then they really start to decline, and this was the case for JW. So her rug at this stage was now 10. She was needing to get help to get out of bed, help to get to the bathroom, and an AKPS of 40. So really spending more than 50% of her time in bed. In fact, probably a little bit more than that. Her goals of care were not for resuscitation, wanting to remain at home, and that was good. But because of this needing to get help in and out of bed, you could identify that she had increased risks of pressure injuries. We would check her pressure areas, bottom, sacrum, elbows, every time we'd see her, and they were all intact. But we're concerned for that. So again, we had the occupational therapist talked with her about pressure relieving mattress, but JW declined. She was a very strong-minded lady, and she really didn't want too many things to make her look like an invalid, but the offer is there. We also had the physiotherapist review her because she was being helped to get in and out of bed. There's a risk both to the carer and to the patient. And there was, as mentioned before, you can have things like pelican belts or things to help move people. And there's just a really lovely a lovely tip to help getting people up who are not as steady or not as strong as they used to be if you don't have equipment. And that's that you slide your arm under their arm and you hold onto their pants so you're kind of facing toward the back. Get them to lean forward and you rock them 3 times, and you tell them, you're going to rock you 3 times, and on the 3rd time we're going to stand up. And it's amazing how much easier it is to get people to do that. And because you got hold of their pants, you're not going to hurt them and you're not going to hurt yourself. But as mentioned, we had to respect JW's wishes. I mean, really, at an AKPS of 40, or we would really be encouraging people to be in a hospital bed, but she was not having it at that point. But safety is always in the forefront of mind. JW was a pretty straightforward lady, and she discussed with me the plans for her funeral. She had been very well organised, and she'd put a bit of thought into it. Basically, I think she didn't want to be a burden on anyone. But I find like lots of people haven't even thought about their funeral, and that's okay. That's not everyone's cup of tea, but it is something that there'll be some activity after the person has died. And I found that there's generally some willing family member, usually a few of them, standing at the edge of the home. They're not quite comfortable helping whoever to go to the bathroom, but they want to do something to help. And they're the people I usually say to, look, you go and do some research about the funerals, funeral companies in your area. You might know, they can ask their friends if they had an experience. I'm not recommending any services over others, but if you designate that to someone else, because people want to help, you give them a job to do. The other thing I always think is helpful is having a younger member of the family. They're very good at putting together photo montages and videos and things like that. So again, giving people something to do they really value that, and also it's hugely helpful because as a carer who's been caring for someone for however many months or weeks, then has to go and organise a funeral, I don't think people have the capacity. Next slide, please. So things were changing quite rapidly. JW's rug was increasing, it was now 11, her AKPS 30, still wanting to stay at home. But she developed some chest pain and some dyspnea. As mentioned, she was a smoker, and she was actually still managing to get out and have a cigarette every now and again, but that's what she liked. She had a non-productive cough. I think she was potentially brewing pneumonia, but we talked about what would she like to do. Would she want to go and have investigations? Would she want to go and have a chest x-ray? Would she want to have bloods? Would she want to have IV antibiotics? We were quite clear in our discussions as to what would she like. At that point, she said, no, it's too much. I want to stay at home. So we said, that's fine. At this stage, the community nurses were coming second daily, and her sister-in-law, who's also a nurse, came to visit from out of state, which was great. But she was getting a little bit breathless, which was troubling her a little bit. And so I provided a breathlessness plan for her. And if you go on to the next slide, please, I can show you an illustration. Thank you. So this is a breathlessness plan. It's a very simple piece of paper, but I've used it with so many people, and it's just incredibly beneficial. What we do is we talk to people about using one of these positions to help when they become breathless, using breathing, slow through pursed lip breathing. So breathe in through your nose and out through pursed lips. Sorry. So they say smell the roses and blow out the birthday candles, and breathe out longer than you breathe in. That's incredibly helpful. But also having a fan is just so beneficial, even for people when they're short of breath and they're dyspneic at the end of life. They're not really able to do any of these pursed lip breathing things. Using the fan on their face, blowing gently on their face, can be very beneficial, stimulating the nerves to tell the brain that they're actually getting enough air. In JW's case, we could advise some opioids. So the next step is, if you've done these things and you're still feeling short of breath, you can take an opioid, which she had, and then we'd fill that in. And then if you still feel that you're not benefiting, if you're still very short of breath or becoming anxious, which makes sense, if people are short of breath, it can make them very anxious, and then being anxious can make you very short of breath. Then you could take a Valium type drug, or in her circumstance was some midazolam as injection. So these things we tell people to go through, practice before you need it. It can be incredibly helpful, and I strongly recommend breathlessness plans. And next slide, please. So
I just popped this in again in terms of being able to recognise the dying person. For most of us that have worked in healthcare for a long time, we know the signs of imminent death, the patient being bedridden, semi-comatose, only able to take sips of water, no longer able to take tablets, with an average prognosis of about 2 days. So being able to support the family to recognise that the last few days have come through being able to recognise these symptoms and signs is important. It also is often something we need to talk through to our colleagues that don't look after a lot of dying people, so that they can recognise that life is coming to an end in the person that they're caring for.
Thank you. Next slide, please.
These needs of the dying person are a list that has been created across cultures and across countries and across languages. I feel they're so powerful because none of them say the needs is to have a super clever doctor, super clever nurse, very expensive medications. but a lot of them are around obviously feeling comfortable, so good symptom control, but feeling safe, feeling valued. I think Robyn has shown so much how JW's control and choice and feeling respected and feeling compassion was so important to her care. Meaningful relationships, touch, reminiscence, and humour. One of the things I'm looking forward to when I come to Bhutan is seeing the Bhutanese sense of humour. But often our patients, and Robyn would know, use humour a lot, and often black humour. So humour is very much part of what people like, and being able to be helped to see a joyous side of life. But also, again, just like Robyn has highlighted in the care of JW, they want realistic goals. And so these needs are the ones that, really across the world, dying people have said this is the sorts of things that they need, and meeting their care needs in the home setting will give them good care.
Thanks, Kirsten. Next slide, please. So communication, as Kirsten mentioned, and also in the previous speakers several weeks ago, is incredibly important. We always practice open communication, active listening, and therapeutic silence. And I think the therapeutic silence was mentioned by the speaker about 2 weeks ago is really important. It's very difficult sometimes to not say things and not fill the gaps with just chatter, but if you can hold that silence, people will tell you lots of important and interesting things. When we were communicating with JW and her husband, I always let them lead the discussion. What did they want to know? They wanted to know about the dying process. We talked about that. It can be really difficult. And when people will ask, do you think so and so, or do you think I am dying? How long do you think I have? Can be very difficult. And of course, none of us have crystal balls, but being as honest as we can be is really beneficial, and gentle and honest. And I just really encourage people who have any work in healthcare should have good communication skills, and there's some fantastic communication skills courses out there if anyone's interested in doing them, or even just practicing. There's some really simple things that were presented the other week that can make such a difference. And I just wanted to put in that as a community nurse, we have often have what we call, curbside or letterbox conversations. And I was thinking this is probably like the hallway conversations after you've been in with the patient, the hallway conversation, in hospital, when you've been in with the patient and had those chatted with them, and then you go outside and you have another conversation. Sometimes those conversations away from the patient are just reiterating the concerns. Sometimes the carer might actually say, I'm not coping, but they'll have said in front of the patient, actually, yeah, no, it's all fine. And so if they're saying if there's two different things, we really need to bring that back and have those conversations. Like, really, we need to be honest, because we don't want anyone to be getting hurt or feeling that they've not done the right thing by their loved one. And we need to caution collusion, and that's, we're talking about something and then telling the patient something different. Next slide, please. So again, into about week 10, and AKPS is deteriorating, rug ADL is increasing, they're still wanting to stay at home. The additional steroids are now every day, so we're using them every day, but even so, the ileostomy is not working, and there's some vomiting. At this point, which is quite interesting, JW was quite unwell, getting quite close to the end of her life. She asked me about TPN, total parenteral nutrition, and because she'd had that experience previously in hospital, it was quite an interesting conversation. So we talked about how when she had TPN when she was in hospital before, that was because she was recovering from the surgery that created her ileostomy, whereas now the TPN, yes, it would give her nutrition, but it wouldn't treat the underlying problem, which was the cancer. The cancer remained. It's not unheard of to have TPN at home, but we try to discourage it if possible. Again, she decided to remain at home because she would have had to go in and have a central line and everything. But we still talked about it, respected her wishes. It was 2 weeks pre-Christmas, and they were talking about wanting to have Christmas together. I really didn't think that in my heart that JW was going to see Christmas on the 25th of December. So I suggested that they have it that weekend, and they did, which was good, which was wonderful. They took them on board. The community nurses were coming to visit every day by this stage. She was still in her own bed. She was really stubborn about that, but she had agreed to a hospital bed in the house downstairs. So we had it all set up downstairs like a hospital bed, bedside commode, and everything was provided. Next slide, please. So we had gotten JW into her hospital bed finally. She had acquiesced and gone into the hospital bed. She was really very comfortable. Her family was staying overnight and taking turns per the roster, but they were also getting really tired. So we were able to get some outside carers, some paid outside carers, paid by the government outside carers to come and give some overnight reprieve, which was hugely helpful. Those carers can't give medication, but if the patient needs the medication, they can go and ask, the husband or the sons to come and do that. But at least the husband and the sons could sleep sound, or more or less soundly, without having to be half awake. The community nurses were coming every day, and they were really focusing on pressure area care, making sure we had turns every 2 to 4 hours. She was actually on an alternating air mattress because she was quite thin, but still had no pressure injuries. We were doing mouth care with sponges and just the bicarb soda, and she was having a bed bath. We'd used the fan to blow on her face for dyspnea, which was quite comforting. And at one point she became quite agitated. She wanted to get out of bed to use the bedside commode, but she was really, really struggling to hold her weight, and it was becoming unsafe. So we put in a catheter. Having an indwelling catheter is not essential. You don't have to have one, of course. Some people are quite comfortable with pads, voiding into pads, but she wasn't, and she was much more comfortable after we put the catheter in. By this stage, all her medications were in the syringe driver. We actually still kept the patch on because her pain needs had escalated, but we had her medications running through the continuous subcutaneous infusion by now. Next slide, please. So JW...
Sorry, Robyn. I just wanted to remind about the time. We have
sorry.
8 more minutes, so just a reminder. Yeah, thank you.
Yeah, nearly done. So JW died peacefully at home and with her family present actually on Christmas Day. Her family were equal parts sad and relieved. The community nurses came the day that she had died. They removed the catheter, the syringe driver. They helped the family to wash and dress her, and they completed what's called a verification of death. When a person dies at home, there's no time frame. You don't need to move the person unless it's for some religious or cultural reason. So they actually kept JW at home. They put the air conditioning on and she stayed with them. And they said it was quite nice. They were talking with her throughout the day and the next day until she was taken to the funeral home. Next slide, please. So my final visit to the family was a bereavement visit. So I popped in, I collected some equipment and answered some questions. I find lots of people have questions about when their loved ones died. Sometimes people...
that are in the state plan already, the caregivers are already in the session.
Sorry.
That they have a better knowledge of the state plan before something happens, and they're ready for it.
Sorry, are you still there? Often people have questions about what the dying process, and perhaps a person had been sitting with their loved one all the time and just popped to the bathroom and the person died when they were there, or whatever. We often have those conversations, and of course there's no right or wrong. We talked about the plans for the funeral, and I offered them formal bereavement, which we do have a bereavement service with our service, which is great. Often people don't need bereavement at the time of death. It might be, sometimes it might be months down the track or even the following year. But we do find in our society, a lot of people gather around and the person is dying, and then they've died, and then the family is still there for the funeral. After the funeral, the family everyone goes back to their lives, and then the carers are left to wonder, or to sit with their grief and their sadness. So it's being able to offer that service is really important. And we do also have a memorial service every 6 months that we invite people to, which is actually really lovely. I'm sure other cultures do much better at remembering people who've died, but at least it's a start. Next slide, please. So these are the resources that I wanted to share with you. There's the opioid calculator that I mentioned. It's available to you. It's very helpful. The Agency for Clinical Innovation has a fantastic palliative care video library that you can access and click on different symptoms. The Care Search is a terrific resource. It's through the University of Flinders and has a whole lot of information for carers, for researchers, for patients, professionals and otherwise. Some advanced care planning website and the palliative care outcomes collaboration if you wish to look into that. Next slide, please. This is just a snapshot, a photo of the ACI, the Clinical Innovations videos that you can look at. You might recognise some of the presenters there, the Melanie Lovell, and you can actually just go and have a look at those. They're really good, give you some good information. And I think that might be it. Might be just references next, please. Oh, there you go, questions, comments. And that's it. Thank you for your attention.
Thank you so much, Robyn, and thank you, Kirsten. I think it was such a comprehensive, you both took us through a journey on how to provide a home-based palliative care, community care, which is often the preferred, choice of patients and families. And as we begin developing palliative care in Bhutan, we haven't yet done a research, but I have a research that is being planned for looking at the preferences of palliative care in Bhutan. And otherwise, anyway, our patients often want to be at home if there's adequate care. I did have patients involved in my research who did say that the home care team from the National Referral Hospital made all the difference to their quality of life, both patients and families. So I think we learned it, the case that you presented, and then how you took us through gave us a lot of interesting way of how we can look at it in our context. Of course, there are little different contextual realities, but I think it gave us so much of idea about how we can innovate things in our way. And as Kirsten mentioned, going to a patient's home is, beyond the stethoscope and the white coat, and being with the family, and how Robyn had journeyed throughout with JW and the family. Amazing. I think it's amazing. I would like to invite participants, if you have any questions, if you wanted to any questions to there's and Dorji. Yeah, please go ahead, sir.
Thank you, Dr. Tara, for allowing me to speak. First, I would like to introduce myself. I am Dr. Namkhadorji. I work as a gynecological oncologist, and most of my patients at one time or another time, they would definitely need palliative care. So at the moment, we don't have, I don't have the skills and knowledge to take care of the patient myself, to give palliative care myself. So I depend on my palliative care team, nurses. And now we have Dr. Kilebuti, who is the palliative care physician, who will make our life easier and the life of patients more comfortable. So in the interest of time, I would like to thank the organizer, the Palladium India, the facilitator, Dr. Tara, and all the faculty members for enlightening us on the issues of palliative care. And for me, it was very informative and very useful sessions. And the most important take-home message I got from this sessions over last 6 weeks is that we have to, anyone can give palliative care, but to give a specialized palliative care, we need some extra skills, knowledge. So in the context of Bhutanese setting, since we are extended family members, looks like all of us are a palliative care physician at our best. And one thing is we are aware of using morphine, and now I hope one day the morphine will be available at the district level and even at the primary health center. So as we have only 1 minute to finish the session, I would like to end once again by saying thank you to the organizers and the faculty members. Thank you very much.
Thank you, sir. It means a lot. And yes, we are building, we are growing, and such sessions have helped us have a better understanding of palliative care. And I think it's 5 o'clock, and I wish we still had more time, but overall, I think, and since the president could not make it, I think there was an intuition that we had a limited time, but I think I had already briefed the president as to what we have done in this course. And so on behalf of everyone in the country, in fact, the president who attended the opening session, and also the president of National Medical Service, and from all the participants, in fact, from all the Bhutanese here, I would be I'm really thankful to apply. And Pallium India, in particular, Odette, Anil, Kirsten, Robyn, Gauri, Smriti, Dr. Sridevi. I hope I didn't miss anyone, but everyone, Dr. Sabita Butala, who did communication, and everyone, and Sangeet and your team, who has done a lot of hard work. I think this is the first of its kind, especially adult palliative care, and all of us are surprised that more than 150 participants have registered, and many have attended all the sessions. So I feel so good that we are learning about palliative care and are really keen to make a difference to our patients. We have learned through our case studies, case presentations, that much more needs to be done to make a difference to the quality of life of patients and their families. So together we will be working on it hereafter, and we will also be organizing many such sessions in the future with help from this wonderful international team. So thank you. And to the participants, I would like to say that we will be sending out a retrospective assessment of the course. So we would appreciate if you could, do the survey, fill the survey. And also, in the meantime, we will get ready with your certificates for all of you who have attended more than 80% of the session. Yeah, and yes, is there anyone who would like to, say something? I'm sure we will take another 3 to 4 minutes if there's anyone just expressing your, views or. Okay. So on behalf of everyone, once again, thank you, everyone who made this possible. Thank you very, very much. Thank you. And I hand it over to Sangeet.
Thank you, Tara. I would like to thank you, Tara, for the immense effort she had taken from the beginning of the session to end of the session. She had made my job 50% much lesser and easier. And I would like to thank all the faculties for conducting this section successfully, all the participants for joining this session successfully in the behalf of me and my team and the Pallium India itself. Thank you very much. Thank you. I hope there will be another more sessions coming up with palliative care in Bhutan. I will be there for your immense support. Thank you. Thank you very much.
Definitely. We need your support, and we will definitely do some more sessions here. Thank you, everyone.
Thank you. Thank you. Joining. Bye.
Thank you. Thank you. Bye-bye.
Bye, everyone. Bye, Tara. Bye.